All right, good morning. I'm Scott Pangonis. I'm one of the Peds ID physicians over here in Akron Children's. And today I'm going to be talking about MISC. Next slide. I have no conflicts of interest to disclose. Next slide. So here are our learning objectives. We're going to try to hit these over the next 20 or 30 minutes. Next slide. So we're going to start with a case. So this is a 4-year-old female who presented to the emergency room with conjunctival injection, vomiting, diarrhea, abdominal pain. She was also noted to have altered mental status and had a lacy macular rash on her extremities. Parents didn't note any fever prior to coming in, but she was noted to be febrile on the day of admission. Her shock index was 2.3, which is the systolic blood pressure over heart rate, and normal for her age would be less than 1.2. So her pertinent labs showed a CRP of 13.7, a sodium of 128. Albumin was low at 2.8. Her absolute lymphocyte count was 882. She had a CT abdomen and pelvis with contrast that showed mesenteric adenitis, and a chest X-ray which showed a normal heart size and with perihilar infiltrates. So she was admitted to the regular pediatric floor with a diagnosis of acute gastroenteritis. Next slide. Okay. So in the ED, she received a 20 milliliter per kilo normal saline bolus, and then another bolus after admission. So she was noted to be tachycardic and tachypnic. They repeated chest X-ray, which showed pulmonary edema. She had a gallop rhythm on exam and required high flow oxygen. Her liver exam was significant for hepatomegaly, so she was rapidly transferred to the PICU. Her labs were shortly repeated. She had a BNP of 113,000, probably one of the highest ones I've ever seen, with a troponin level of 212. Her shortening fraction declined from 33 to 5 despite maximum vasoactive support. So the ECMO team was activated and she was cannulated on the VA ECMO. Next slide. So this is probably one of the more severe cases. They're not all like this, but it's just to give you a flavor for how severe this can be. So coronaviruses are positive strand RNA viruses, and they're also enveloped. They're broken up into 4 different genera: alpha, beta, gamma, and delta. This is different than the lineages that you're going to hear on the news and from many different organizations. And the SARS-CoV-2 viruses belong to the beta coronaviruses. For symptomatology, these mostly cause upper respiratory tract infections, although some of the coronaviruses can cause GI symptoms such as SARS-CoV-1, 2, MERS, and one of the OG coronaviruses. Next slide. So what is MIC? So this was initially described in the UK with children having a post-inflammatory syndrome during the COVID pandemic and subsequently spread to the rest of the world. So probably the most important thing to take away from this is an acute febrile illness with multi-system involvement, and it overlaps with other systemic diseases such as Kawasaki's macrophage activation syndrome and toxic shock syndrome. Next slide. So we tend to see this about 2 to 6 weeks after somebody's illness, if they had a noticeable illness. And as you can see from the graph here, you have the number of positive cases going up and then following the number of MISC cases going up. And we also saw this again during the Delta surge, which started probably back in July. And our first case here of MISC from this surge started by mid-September. Next slide. So there's a slight male predominance with a median age of 9, which is much older than our typical Kawasaki's patient. According to the CDC data, it doesn't seem to be a racial predisposition or racial predominance in their data. Depending on what data set you look at, it looks like Hispanics may be more likely to develop than Caucasians. That may be because that population has more cases of COVID, although it seems to affect African-American non-Hispanic patients disproportionately, even out of proportion for their number of cases. And this, the incidence is about 1 in 400 or 1 in 4,000 cases after COVID. And the severity of the acute illness is not predictive of developing MISC. So a lot of our patients never had any symptoms, and some of them didn't have any known exposures to COVID. Next slide. So there's a lot of symptoms listed on this slide. I'm going to try to hit the high points. The fever is found in 100% of patients, subjective or objective. It's usually, according to most of the definitions, it's more than 24 hours. For our patient, depending on the severity of the illness, we kind of assume that maybe they had a tactile fever or they didn't take a temperature. So fever, 100% of patients. And the next most common is GI symptoms. So nausea, vomiting, diarrhea, abdominal pain. So if you do imaging, we've seen ileitis, colitis, duodenitis, appendicitis. Imaging, these are not uncommonly seen in these patients. And also some of them will also have elevated transaminases. Cardiovascular is the next most common, so shock, distributive or cardiogenic. They can also have chest pain or signs of acute heart failure. And this also includes elevation of BNP and troponin. And the rate of LV dysfunction or myocarditis is anywhere between 30 to 55%. The most recent estimate I saw of myocarditis was 8 to 18% of MISC cases using the CDC definition for myocarditis. Pulmonary symptoms was reported in the CDC data set as being common. I think some of this overlaps with the cardiovascular, the cause of these symptoms. And the dermatologic and mucocutaneous, or your Kawasaki's-like symptoms. These seem, at least initially with the alpha strains or the alpha variants, were described more commonly in the younger patients. We do also see these in older patients, though. So I would look for these symptoms in all patients, regardless of age. So neurologic includes headache, confusion, altered mental status, and meningismus. So some of these patients present with hallucinations or signs that may be indicative of meningitis. So keep this on the differential. And then the least common are acute kidney injury and then cervical adenitis. Next slide. So there's going to be a lot of symptoms here that you're going to see in your office probably every day, and they're going to overlap with a lot of illnesses that are probably more likely to be the diagnosis. So think more severe or prolonged than expected for an acute viral illness. So someone comes in with severe abdominal pain or diarrhea that's lasting longer than your typical norovirus. Next slide. So here are the lab findings from our New York colleagues. And these were used to establish cutoffs for the American College of Rheumatology guidelines. So CRPs were elevated with a median value of 22, and about 99% of these patients were above 5 milligrams per deciliter. They also had signs of hyperinflammation, as you can see from these other labs. And 66% of them had an absolute lymphocyte count less than 1,000, or if you're less than 8 months, it'd be less than 4,500. They also had elevated D dimers with a median of 2.4. 90% of them would have an elevated NT-proBNP, and 71% had an elevated troponin. Next slide. So just to kind of break it up into what can be consistent and not consistent, and this is not an all-inclusive list. So consistent, so things that look like Kawasaki's disease, especially in an older kid, or Kawasaki's disease with GI symptoms. Fever with GI symptoms and other symptoms involvement. So fever, GI symptoms, and conjunctival injection, or headache, stiff neck, especially fever, GI symptoms, and shock. I would keep this in it. So hopefully those patients aren't presenting in your office in shock. Or other some of the other symptoms that are a constellation of findings as I described in the previous slide. Fever, GI symptoms that are just not really feeling like a viral gastroenteritis. So things that are not consistent. So chronic or relapsing symptoms, they're probably either unrelated or could be possibly due to long haul COVID or post-acute COVID syndrome. So no fever, MISC is unlikely, and normal inflammatory markers. Like this is a hyperinflammatory state. And usually their CRPs are 10 or more, but it's got to be at least 5 or more. Next slide. For diagnostic testing and the CDC cohort of, I think it was about 450 patients, or almost 500 patients, the ones that they tested were positive either by serology or by PCR, and the other 5 patients had an epidemiologic link. We are now, just to try to minimize the number of tests we're ordering on these patients, if they have a documented PCR within 6 weeks of presentation, then we do not send additional PCR or antibody testing. The previous ones that we've tested that had a documented PCR in our thing always came back positive. Next slide. So I'm going to briefly go over some of our management guidelines. Next slide. So over here, the first thing that we do if we're concerned for ever MISC comes up is we see if they meet the fever criteria, epidemiologic link. It's probably not as pertinent, especially when there's ongoing community transmission. And then they have to have at least 2 clinical features or 2 systems involved. So GI and cardiac would be most common. Tachycardia, we haven't been counting as a symptom just because it's common and it can be very nonspecific. From there, we do our ABCs, take a history. We try to limit our bolus size to small volumes in case we're worried about developing cardiogenic shock or heart failure. From there, we kind of break patients up into sick or not sick, and then base our workup on that. And we do some of our more extensive workup, including coags, LDH, and some of our other labs just for our sicker patients that are probably going to end up in the ICU. Next slide. And from there, after we get our lab workup, then we see if they meet the lab criteria. So CRP greater than 5. We used to use it also or an ESR greater than 40. However, that's as you see with our previous patient who had an ESR of 10. We've also had patients who had ESRs over 40 with a low CRP, and those patients end up doing fine and not needing treatment. In addition, you have to have one of the at least one of these lab findings, and most of them have at least one or more than one. And say if you don't, then we say MISC is less likely. If they're in the ED and they're not admitted, we say follow up with somebody within 24 hours. And if they're in the hospital, we see how they are. And if they're getting worse or their fever's persisting, then we repeat the workup. Next slide. So based off here, we decide basically whether they need to be in the ICU, and we call them severe, or if they're not, they can go to the regular pediatric floor. So severe is basically if you're needing vasoactive support, invasive or non-invasive respiratory support, if we're concerned for rapid progression, or if we have any of those other findings. Next slide. Some of our workup differentiated between, so if you're mild or non-severe, you get IVIG, which the severes also get. Lower doses of steroids, and then we wean it over 2 to 3 weeks, and then low dose aspirin. Whereas the severe, we'll give them the high dose steroids for at least 3 days, usually for at least 3 days, and then we wean the steroids over 6 to 8 weeks. And this, we usually have an endocrinologist see them towards the end of that. This is important for pediatricians because these patients are going to be at risk for adrenal insufficiency. So if they're presenting with any kind of signs of any of those signs, like if they're sick or if they have fever, they have to have a sick day plan. So have them get in contact with those specialists. And if you have any severe LD or severe LV dysfunction or need for vasoactive medicines, we'll also add anakinra, which these kids seem to respond very well to anakinra or steroids. Next slide. So what should I do if I suspect a patient of having MIC? Probably these patients probably should be evaluated in the emergency room. However, if you have a child in your clinic and he looks good and you're able to get labs very rapidly, you can consider a CRP, CBC, and a CMP. What we've been doing, if we have patients come to our clinic, we try to get them and order them stat and have them sit in our waiting room. If we can get those back within an hour or so, that's something that we can do in a low-risk patient. So these patients are at risk for rapid decompensation, and you can't really tell who's going to go on to develop a severe disease. Next slide. So in the 2 weeks after going home, it's important to watch out for fever. So I had a patient a few weeks ago who developed fever and recurrence of her headache and abdominal pain, but also developed respiratory symptoms. So it was rhino positive. Like, well, not a great time to get sick with other things. So fever and elevated CRP to me is recurrence of MISC, and it's treated as such. So if they call you with fever after they go home, get a hold of the specialist that's managing them and let them know that they may need to be either evaluated or readmitted. Then we give families and the pediatrician all the information of what they need to know and what they need to look out for and who to contact. Next slide. Our MISC committee is made up of many different specialties, including ID and cardiology, including Dr. Ira Taub. Next slide. That's my references. And thank you for your time.
Okay. Thank you, Scott. Let's advance the slide. So my only disclosure is that I am sandwiched by two very bright people from infectious disease, and I'm very partial to infectious disease. And if you think a patient might have this, you need to call one of them. Next slide. I'm going to present a case of a young cancer survivor who went off treatment when he was about 6 years old, and came to our hospital in January of 2021 with a fairly classic presentation of MISC. He had fevers, emesis, abdominal pain. There was no exposure to COVID-19, and in this case, the family had been very meticulous to avoid exposures because they knew that their child had some risk factors, but despite everyone's best efforts, these things do happen. In our emergency department, he was actually hemodynamically stable, but when we got an echocardiogram, there was some systolic dysfunction, and there was a significantly elevated troponin, not just transiently, but over more than the first day or so. He came to our PICU, was started on an enalapril, got his appropriate treatment, and turned around and did fantastically, and then he went home. And what I want to focus on is the "and then he went home" part. Next slide. As the pediatrician seeing this patient, the first thing you have to remember is this is an 11-year-old boy who is now feeling better. And the first thing he wants to know is, when can I play ball again? So is it safe to clear him for sports? The second question is, well, he was pretty sick from a cardiac standpoint for a couple of days. How do we know when things have normalized? And the third question is, well, what are the long-term cardiac risks? And the fact that this child got chemotherapy at a young age, how does that figure into the equation? So with those three questions in mind, let's go to the next slide. Okay, so as background, should we be worried about an inflammatory cardiac disease in a leukemia survivor? Absolutely. Anyone who has been treated with chemotherapy, especially at a young age, especially with an anthracycline-based chemotherapy like doxorubicin, is at risk of long-term cardiac dysfunction. It is dose dependent, but there is no safe dose. Over the long term, you're talking about maybe 5 to 10% who will have some form of cardiac dysfunction, but certainly having this additional hit to the myocardium is quite concerning. Next slide. I do need to address briefly a pet peeve. So pediatricians want to know if they can clear a child for sports. The problem is there's a lot more to it than, okay, you need to order this and that test. Just because at one point in time things are safe for a child doesn't mean it's a permanent state of being. And particularly when we're dealing with a new disease, we have to be very careful with words like clearance that imply something permanent and unambiguous. Next slide. The other important preliminary is that you're not just clearing the child for sports, you're clearing him for life. If you look at the diagram on the right, one of the largest series of sudden cardiac death demonstrates pretty clearly that when people die from cardiac causes suddenly, it's not necessarily when they're exercising. Actually, that's a minority of the time. And many of the forms of structural and arrhythmic heart disease that cause sudden cardiac death, we really don't understand the circumstances under which this happens. So if a child plays the tuba instead of playing sports, or plays video games instead of playing sports, or does nothing instead of playing sports, that does not necessarily mean that he or she is not at risk. Next slide. So the real way to think about is the child at risk is, which of the common causes of sudden cardiac death might happen to a child who has had this disease? This is a great series of sudden cardiac death in a pretty large cohort. And when you look at children from really very early ages to young adulthood, congenital heart disease is a pretty big chunk of that. And with this disease, generally, we can take that off the table, which leaves us with things like ischemic heart disease related to the Kawasaki-like syndrome, and myocarditis related to the myocardial inflammation. And so the question is, well, which of these things happen, and which of these things that happen tend to last and create ongoing risk? Next slide. We know a great deal about what happens acutely. And as my colleague alluded to beforehand, it is very, very common for these patients to have off-the-charts cardiac enzymes. Depending on how you define myocarditis, either as some degree of systolic dysfunction, a pericardial effusion, new valvular regurgitation, around 50% will have something like it, and a significant minority will have some degree of shock. And then lower down on the list, you'll see coronary artery abnormalities, where the coronary arteries are either dilated or outright aneurysmal. And way down on there, you'll have shock, need for ECMO, and rapid demise. It doesn't happen all the time, but it does happen. Next slide. These things are very common in the acute setting. And by the acute setting, I mean within about a day of presentation. Anecdotally, I find it's around hospital day 2 to 3 that these kids are really at their sickest. But the sickest is, as the name implies, multi-system. So it's a little bit of renal failure, a lot of respiratory distress, and yes, high troponins, systolic dysfunction, some fluid overload, kind of happens at the same time. And if a child is going to deteriorate, they're going to deteriorate at that point. Next slide. But at least the cardiac findings tend to resolve quite quickly. A child with myocardial dysfunction at that 3-day very sick point will often normalize that function either just before or just after discharge. And even in kids that have coronary artery aneurysms, those aneurysms tend to resolve, in my experience, even quicker than in Kawasaki disease. Next slide. There are some cohorts from the centers that saw this first, New York and the UK. And the general trend is that, yes, these children are very sick when they're in the hospital, but by the time you get to a month to 3 months of follow-up, 80, 90%, you would never know that the heart was sick. Their exam is normal, their EKG is normal, their echoes are basically normal, and everything from that point on is speculative. Next slide. So lacking any long-term data on these diseases, we have to go to 2 models. One is myocarditis, and kids have been getting myocarditis for a very long time from viruses, or Kawasaki disease, which is now about 50 years old. And in both of these cases, we know a lot about the long-term outcomes, and we have a pretty good fund of knowledge about how to manage these kids in terms of sports and in terms of safety. Next slide. Myocarditis, as many of you know, can either lead to acute decompensation, or over the long term, it can lead to a cardiomyopathy that eventually degenerates either into heart failure, sometimes requiring transplant, or sudden cardiac death. The general data that we have for myocarditis in pediatrics, and probably the best known series is in this panel on the right side of the screen, is that around 2/3 of these patients with acute myocarditis will show normalization of their echocardiogram within 2 to 5 years. But you have this 20% or so that are going to deteriorate and are at risk for sudden death. And I suspect that unfortunately there are some post-MISC patients, MISC patients, who are gonna fall along those lower lines. And these are the ones where, as a general pediatrician, you need to watch out for them. Next slide. In terms of Kawasaki disease, we know that when something goes wrong with your coronary arteries, it creates a mildly increased lifelong risk for myocardial infarction. But when there's something really wrong with the coronary artery, like an aneurysm that doesn't go away, you're at risk for rupture of the aneurysm, you're at risk for myocardial infarction. And an open question, and one that I hope researchers will be able to answer in the next couple of years, is is the pathophysiology in MISC the same as that in Kawasaki disease in terms of a necrotizing arteritis? If it is the same, we know a lot about how to manage that pathophysiology, and it should be translatable into MISC. Next slide. The long-term data that we have, primarily from Japan and a bit from Europe, is that patients who have had bad Kawasaki disease with medium to large coronary aneurysms are at significant risk over time, sometimes double-digit risk of MIs. And in some cases, these are people who are 25 years old and have already had coronary artery bypass grafting. So in a MISC child who is the rare case with significant coronary artery aneurysms, these are cases where I would be quite conservative. Next slide. In terms of the template for how to treat these kids long-term, I think we can more or less copy and paste from either myocarditis or Kawasaki disease, depending on the clinical presentation of your particular MISC patient. The guidance for myocarditis is essentially 3 to 6 months of restriction from competitive sports. Competitive sports means something very different for a 16-year-old basketball player on a high-level high school team versus a 5-year-old who wants to play t-ball. I think the former you have to be much, much more careful than the latter. And it's very, very important that you tell the high school athlete, it's not just that you shouldn't be playing basketball games, you shouldn't be working out with your team, you shouldn't be doing informal scrimmages. Athletes are very creative with excuses to get back into sports. Next slide. Regarding Kawasaki disease, it depends on the size of the aneurysm. And if the aneurysms have resolved after 6 to 8 weeks, as is commonly the case in MISC patients, usually at that point you can start slowly reintroducing them to sports. But in patients that have a significant sized coronary artery aneurysm or other signs of myocardial damage at the same time, those decisions need to be made very carefully and with multidisciplinary involvement, because these are patients who can be quite complex, are at risk, and may in fact even need interventions or really involved medical strategies like dual anticoagulation. Next slide. So the bottom line for children like this is that yes, they're going to be sick in the acute setting in a life-threatening way, but it's really amazing. They get their treatment and 3 days later, in many cases, they look like a new child. Long-term, the anticipatory guidance you can give them when they show up in your office after discharge is, no, you will not be going back to practice next week, but yes, there is hope for you playing a sport next season. And with rare exceptions, what was wrong a week ago is going to go away. The problem is we still don't know who will be a rare exception. And just as a denouement to my initial case, I actually had the privilege of seeing this patient about 10 days ago. He's almost 9 months out. Everything has normalized, and I was able to clear him to go back to playing ball. So in this case, a happy ending. Thank you very much.
Okay, well, that makes it my turn. So I'm Amy Edwards. I'm up at Rainbow, and I get the dubious pleasure of having to follow 2 great cases. So I had to come up with something really interesting for you guys. Next slide. So I have no conflicts, and I don't know why I said that. Actually, everything that I'm going to be talking about is off-label. I'm sorry, I missed that in my disclosures. Next slide. So we're going to talk about a patient who taught me a lot about Misty. This was a 4-year-old Black male who came in with 4 days of fever, abdominal pain, and very watery, non-bloody stool. Interestingly enough, his fever went up to 105, but it resolved 2 days prior to presentation. On the day of presentation, he went to his pediatrician's office. He had an ESR of 100, CRP of 27. He was found to have acute kidney injury, and his COVID PCR was negative. When the PCP saw the lab results, he sent the patient to the ER. Next slide. In the ER, the patient was noted to be afebrile, but very tachycardic, tachypnic, kind of soft blood pressures. He was given 3 boluses, and his blood pressures, got a little stronger, but he had really significantly worsening abdominal pain. He was diffusely tender with a tense and hard abdomen. He was given ceftriaxone and vancomycin. He had chest X-ray, which showed a borderline cardiomegaly. His KUB was normal. Surgery was consulted. They came down. They did an abdominal ultrasound. They found some free fluid with gallbladder thickening. They were able to visualize his appendix, which was normal. They got a bunch of labs as part of our, they suspected Misty early in him, and they found a troponin of 2.5, BNP of 2000, very elevated CRP was almost 40. And the rest you can see there is slightly hyponatremic. Next slide. So he also had conjunctival injection. He had some anorexia, malaise, diarrhea. He had decreased urine output. He did have a rash on and off. On physical exam, they found a gallop murmur and hepatomegaly. So he was admitted to the PICU for worsening blood pressure and concern for cardiac involvement. He was intubated and an epinephrine drip was started. Next slide, please. So a brief history. He had been previously healthy. He lives with his extended family. He had traveled to South Carolina in the month prior, and he had multiple known COVID exposures starting about 5 weeks prior to presentation from multiple family members, although he himself did not have any COVID symptoms. Next slide. So he had blood and urine culture sent, started on broad spectrum antibiotics, as anybody who comes in what looks like shock should. They were only able to do a partial echo right at the beginning. So there was kind of this back and forth. He was 4. So was it Kawasaki? Was it Misty? It wasn't very clear. So he started off with IVIG and aspirin. And then the aspirin was actually stopped, and then he was given high-dose steroids when his full echo showed there was no cardiac involvement, and he actually improved rapidly after steroids. Interestingly, his COVID PCR was intermittently positive for reasons that aren't super clear to me. They actually sent it multiple times, and it would sometimes be positive and sometimes be negative. But of course, his IgG returned positive. About 36 hours after his steroids were started, he was extubated, the epinephrine was stopped, his belly pain improved. He was really perking up nicely, but later that same day, he was found unconscious with blood on his mattress and on his clothes. And an angiogram showed an active arterial bleed in the proximal duodenum. Next slide. An EGD was done. They found an ulcer actively bleeding, and it was clipped. The steroids were stopped as it wasn't clear if the bleed was from Misty itself. As you guys will recall from a couple slides ago, he came in with pretty significant GI symptoms. So was it that, or was it the high-dose steroids themselves? However, 2 days off of steroids, and he became very hemodynamically unstable and had to be re-intubated, and his epinephrine was restarted. He had some evidence of very mild adrenal insufficiency, but unable to account for the severity of his symptoms. His CRP, which had gone down very rapidly, started to rise again, and he actually had some fevers as well. So the patient was actually started on anakinra. And after the anakinra, he was stabilized extremely rapidly. He was extubated, and the epinephrine was stopped in less than 24 hours. And he was kept on anakinra for 2 weeks. Next slide. So the reason why I chose this case in particular, especially since I'm ending this series, was to really talk about we know about the IVIG, we know about aspirins and steroids, but what about the other patients? And this patient, there's a couple of things I want to point out about this patient. One is the idea of rebound MISC, which we have seen in both the acute setting like this in the ICU, but we've also seen it, well, I wouldn't say I have seen it. A colleague of mine, Dr. Oberly, down at Nationwide, reports seeing some kids have rebound, after discharge. And so that's one situation that I wanted to kind of raise a little bit of awareness about. It seems to be very, very rare, but it does happen. And the other thing is that not all kids respond to IVIG or steroids, or if they do respond to steroids, they're not a good candidate for continuing the steroids because of how much MISC can affect the gut. And so anakinra is something that we actually use at Rainbow quite a bit, either together with steroids in very severe patients or actually in place of steroids in patients that we're uncomfortable using steroids in. Next slide. So the latest recommendations from the American College of Rheumatology is that all patients with MISC that are severe enough to be admitted to the hospital get IVIG. This is based on the fact that they can rarely develop coronary artery aneurysms, and as we know from Kawasaki, IVIG reduces that risk of coronary artery aneurysms. So that's the current recommendation from the American College of Rheumatology. So there are 3 studies actually now that show that if you give steroids and IVIG together, you have better outcomes and more rapid resolution of symptoms than if you give IVIG alone. There is one study that shows no difference between IVIG and steroids. So I think the data leans towards IVIG alone is probably not enough, but it's not super conclusive. I will say that the McArdle study did show that the rates of coronary artery aneurysm are the same, regardless of which treatment is used, regardless of whether you used IVIG or steroids or IVIG and steroids together or no IVIG. However, coronary artery aneurysms are such a rare event that it's not clear if the study was powered to detect a difference. And in fact, most of us guess that it's probably not. So it's unclear at this time if IVIG prevents coronary artery aneurysms, but on the off chance that it does, the current recommendations is for all patients to get IVIG. Next slide. So having said all of that, I just wanted in the time, a few minutes that I had left, to talk about what some possible causes for MISC might be. There's so much that we don't know about the pathogenesis of a lot of things related to COVID, and that stands true for MISC as well. But there are a few things that we've learned about MISC in the last year and a half. Unfortunately, most of the studies that have been done compare kids with MISC to kids with acute COVID. And the problem with that is that we know that kids who have MISC are 2 to 6 weeks out from their acute COVID. And so their immune response is naturally going to be more mature, even if it's deranged. And so some of the comparisons aren't super immunologically relevant or clinically relevant, but still every bit of information is good. So for instance, there was a study that found that children with MISC had more antibody-dependent cellular phagocytosis than children with acute COVID. But again, is this pointing towards immune overreaction, or is that a function of time? Because you would expect to see more antibody-dependent cellular phagocytosis over time as the child's immune reaction matured. However, you wouldn't expect to see it 4 weeks out. So is that part of the derangement that's happening, like somehow that's being reactivated? That same study found that pediatric patients with MISC had a greater proportion of IgG1 subclass spike proteins than IgG3 when compared to children with acute mild COVID. What relevance that might have is not really well known. It's just more descriptive, kind of pointing out that there are some differences. And then there was another paper that came from a group that previous to COVID had actually been studying toxic shock syndrome. And as many people know, there is part of what drives the shock syndrome, part of toxic shock syndrome is this bacterial superantigen that can really push a T cell clonal expansion that is a maladaptive response. And that same group that does the toxic shock work looked at some of the MISC kids that they had, and they did find kind of the same idea of T cell clonal expansion driven by a type of what they describe as a super antigen. I don't know, for me, that was maybe a little bit of bias, like they because that's their field of research, that's kind of what they found. But there is no doubt that they did find a trend towards this clonal expansion that appeared to be maladaptive, which makes sense because you're getting a maladaptive response, so your immune system is probably not adapting properly. So it kind of makes sense. Next slide. And then this was actually one of my favorite studies. This group was looking at, was interested in understanding why such a huge percent of patients had GI symptoms. That's not something that we see with a lot of other inflammatory syndromes. Like if you think of Kawasaki and things like that, you don't see, a lot of those GI symptoms. And what this group found, so what they did is they took kids that had MISC and they did nasopharyngeal swabs, and then they took stool samples, and they were actually able to find detectable levels of SARS-CoV-2 in the patient's stool, even when it was no longer detectable in their nasopharyngeal secretions. And so the authors were wondering, could this antigenic persistence in the GI tract be at least partially responsible for why the vast majority of MISC patients have ongoing GI symptoms. And I would love to see this data expanded to other groups. The other thing that they did with these kids is they looked for evidence in the bloodstream of microbial translocation, which they found, indicating that the gut is inflamed. And so you're seeing some of that microbial translocation. And the question is, how much is that translocation feeding into this inflammatory cycle? All of that, still to be determined, but it's certainly some interesting data. Next slide. I believe that's, yeah. So here's my references, and I will open it up for questions.
Thank you all for just a very fascinating, sort of thought-provoking sort of review on MISC. It truly is scary. And I think, for those of us in primary care, I bristle when I hear this, comment from parents when I talk about immunizations. And, that first thing I always hear is, well, look, kids don't get sick, right? And, while luckily, if you look at the mass number of kids not getting sick, but I think, talking to you all and sharing what you all are seeing and our other colleagues in pediatric emergency departments and pediatric intensive care units and seeing, how sick these kids can get, I think it's very topical and very timely. So thank you very much. I'm going to encourage, if you have any questions in the chat, I know some of our panelists have been sort of answering those as we've gone. I'm going to see if there's any that we haven't hit yet. I think we're good. Let me see here. Okay. So I'll ask one of you, and you may not know, because depending on sort of if you see these sort of long COVID kids, could one of you maybe comment on what's sort of the longest amount of time now? I mean, we're almost, we're definitely getting close to 2 years into this now. What's sort of the longest time frame where you've seen patients still sort of with some sort of symptom post-COVID that you think probably was related to their COVID?
So I think I have one patient who I think it's been a little bit over a year now, who still has fatigue, brain fog, and cough. She's about a year out, and now has been vaccinated and her symptoms haven't gotten any better.
Great. Thank
Yeah,
you.
I would, that same. So I'm the director of our COVID recovery clinic, and I do all of our long COVID stuff. And I've got kids. Actually, my longest kid actually got COVID in the summer of 2020 and is still with me in the COVID recovery clinic now more than a year out. And he's getting better slowly, but still is doing primarily online school because he's so fatigued he doesn't have the energy to go in person. And yeah, it can last a really long time. I will point out that I have not seen any of our MISC kids, even with all this inflammation, go on to be long haulers. Most of our long haulers have about a week to a week and a half of acute febrile illness, get marginally better from their acute illness, and then relapse into like a more chronic type picture.
Sure.
Whereas our MISC kids, once they recover, appear to recover fully so far as I can tell. I follow both the MISC kids and the COVID long haul kids, so I get to see both of them. And so it's really interesting how that post-COVID sequelae appears to be one or the other. As far as I can tell, it doesn't appear to be both.
Sure. So I'm going to come, there was a question in the Q&A as well as a comment. I'm going to kind of combine these because they're very related. One comment that you may see in the chat box was, are there any concerns that we'll start seeing more MISC after kids start getting vaccinated? And then the question related to that, similar, has there been any evidence in the Pfizer clinical trials that vaccination may prevent MISC?
To address those two questions, I don't know if the evidence will be argument from silence, meaning there's 4,000 kids in the last 18 months that have gotten this disease in America. 18 months from now, I am hopeful that we will see a lot less. And I think that'll prove itself over time, but it's going to take time. Regarding MISC specifically post-vaccination, we have seen a myocarditis post-vaccination. We've had a handful of kids, I think about 5 at Akron Children's. It is a very wimpy myocarditis. The kids are better in 3 or 4 days. Really, in most cases, they don't even need to be treated. There are a handful, and I mean really a handful of case reports of adults having a syndrome that's very much like MISC-C after vaccination. I would say the incidence is probably 1 to 2 in a million. So it can happen, but I don't think it will be something that a general pediatrician will typically need to worry about.
Sure. If, so some of you at your institutions have sort of a dedicated sort of post-COVID, long COVID clinic. If you're practicing in an area that doesn't, and you're seeing that child that had COVID, they want to return to sports, but they're having shortness of breath, and maybe Dr. Talbot, I'll pick on you since you're the cardiologist in the group. You know, sometimes, who should I send those kids to? Should those kids go to cardiology? Should they go to pulmonology? What would your advice be to the primary care pediatricians?
I get sent a lot of kids who have not necessarily MISC-C, but post-COVID plus shortness of breath plus fatigue. And the goal is to see if it's a cardiac cause. And it pretty much never is. Right. And honestly, I don't know what it is. I have pulmonology colleagues who pretty much substitute cardiology for pulmonology, and they do their thing, and there's nothing necessarily wrong with the lungs. I think if a kid isn't acting right, you have to rule out the most dangerous things. But ruling out the most dangerous things in, let's say, a rural or resource limited setting isn't necessarily, you know, having the family travel for 3 hours to see a subspecialist. You can, for example, you can do a chest x-ray. You can draw troponins and a BNP. You can contact a cardiologist at a nearby center, and we can help you through about 80% of the workup right where you are. Thankfully, we haven't seen a gigantic wave of sudden cardiac death since kids have gone back to school and gone back to sports and the like. which doesn't mean it's not going to happen. But I think the risk is what it's always been. And, 10 years ago, kids were getting viral myocarditis and things like that also. And, you look for clinical findings and you look for things that made you suspect it, and you did the best you can. And I think we're all going to have to do the best we can with this for a while.
Great. Okay, I think we've got time for one more question, and I'm going to, again, kind of combine a couple here because they sort of really look at treatment and how you handle these patients sort of long-term. There was a question about recommendations on treatments for long hauler symptoms like fatigue, cough, brain fog. And then Dr. Dritz had put in, and Scott actually just recommended that. So there was a comment about, or a question about, I just lost it now. Oh, recommendations for vaccination after someone has had MISC or long haul symptoms. And I think Dr. Pangoas responded to the one that you wait 3 months after MISC. You can vaccinate someone after acute COVID as soon as they're out of quarantine. And I think I would agree with that's in practice what we're doing. But would any of you maybe comment on sort of the approach you take to these kids and how you deal with their fatigue, their brain fog, their sort of those cognitive defects or deficits, I should say?
So for the long haulers, the most important thing is to provide full wraparound care. These kids are pretty distressed, as are their families, at losing, their normal daily function. One of the most important things is to listen to them and to make sure that they feel heard about what they're going through. I've gotten a lot of people, by the time they come to the COVID recovery clinic here at Rainbow, they're telling me that they feel like they're crazy because their doctors are telling them there's nothing wrong with them and that they're fine and that they just need to push through and they'll feel better. I think the most important thing is to listen to the patient, and then you basically focus on the area where they're struggling and really try to support them. So with fatigue, you need to work with their sleep hygiene, making sure that they're getting really good, effective sleep. What is their nutrition like? Nutrition is a really neglected part of overall human health here in the United States, unfortunately. COVID is very inflammatory. So in our clinic, we try to focus on a very anti-inflammatory diet, a very antioxidant rich. So we're talking about fresh fruits and vegetables. We're talking about whole grains. We're talking about nuts and seeds and things like that, healthy oils and things like that. But that is expensive. It costs money. And that can be a real struggle for some of our patients. All of our patients, we do depression and anxiety screens because that can be a real hidden symptom of long haul. And it's really just about supporting them. We work with the schools. A lot of my long haulers have IEPs so that they can get additional support at school. It's not dissimilar to how you might manage like chronic fatigue syndrome. So if you have somebody around that does that they can help. But it's a lot of work. The long haulers, there's no doubt about it. They take a lot of support and help and work to help them.
Thank you. And I'm not sure if Dr. Logan's on or not, but I really kind of have found in my practice, it's a lot of similar. You had mentioned chronic fatigue. I think it's sort of similar to concussion, sort of that concussion management as well. So, and I'm really, Amy, thank you so much for mentioning the mental health. That obviously ties into our earlier keynote session, and unfortunately is such a big deal. So, well, thank you to our panel and speakers, Drs. Taub, Pangonis, and Edwards. This was very timely, and it will be interesting. I think we will hopefully be interesting to